Hello children. This is the series of presentations which we are providing you as a revision before your examinations. So I will be talking on dacryocystitis. Dacryocystitis might be given to you as a short case, and in rare instances it might also be given to you as a long case. So in these times where patients are in dearth, so you might have dacryocystitis as a long case, but be rest assured that dacryocystitis as a case will be given only a chronic dacryocystitis. A chronic dacryocystitis will be given in adults, and pediatric cases will not be given to you. Now, what I will be talking today is basically from the perspective of an examination case. So how do you present your case? Now be very careful and please pay attention to the questions that are being asked by the examiner. So the examiner may ask you A, what is your case, or B, present your case. Mainly if it's a long case, then the answer in either instances is slightly different. For the first one, you may proceed with, I was presented with or given a case of chronic dacryocystitis of the right or the left eye, as the case may be. And then it will be followed by questions and crossings in which he will ask you, why do you think it's a dacryocystitis? What a dacryocystitis is? Why do you think it's a chronic dacryocystitis? And in the second, that is present case, this is a bit lengthier. It is usually in a long case, and here you'll have to say, for the second, you'll have to say, my case presented with a complaint of watering of the left or right eye, whichever eye that is, with occasional complaints of swelling, pain, and redness over the last. You have to mention the duration of the disease, and you may also state that he had additional complaints of regurgitation of mucopurulent or purulent fluid from the punctum. And hence my case appears to be a case of chronic dacryocystitis. Mention the eye, please. So please bear in mind the difference between the two. It is at the very beginning that you make an impression on the examiner. Now, what are the chief complaints? So watering will be a chief complaint here. Additional complaints must also be elicited, like the duration of the disease, any history of trauma, local trauma, history of drugs, especially drugs instilled in the eye, anti-glaucoma drugs, or like 5-fluorouracil, which is given. History of surgery may also involving the nasopharynx may also be taken, or the orbit must be elicited. Malignancy and the history of irradiation, which has been locally given, should also be taken. History must also be there, be taken if there were occurrences or recurrences of redness, pain, swelling over the sac area, because it is very common for chronic dacryocystitis to have episodes of acute on chronic dacryocystitis. Now the examination. See, if you look at this slide, you will find there are certain pictures, and this is how the sac region might be looking in the case which you'll be given. So the first one is an infant, obviously, and he's having a congenital nasolacrimal duct obstruction, and this can be safely omitted because you'll not be given an infant. The second is a tense mucocele, that is tense mucocele or an encysted mucocele, and these are usually not compressible and they are painless. Third one is the one which is swelling, and these swellings are the ones which, if you do a ROPLAS, I'll tell you what a ROPLAS is later on. So you will have mucopurulent fluid coming out from the punctum and the sac emptying. And the fourth one is a fistula. If you see very carefully, you will find a teardrop at the end of the fistula. And the fifth one is a multiple discharging sinus that you can see. And the sixth one is having a brawny induration over the sac area, and this is a result of an incision and drainage which is done in a case of tubercular dacryocystitis. Now here's a tip. Since the chief complaint of the patient is chronic dacryocystitis is watering from the eyes, we must look for the causes of epiphora in this patient. And of course, one might be asked the definition of epiphora, the causes of epiphora here, because as and how you present a case, whether it's a short case or a long case, your examiner might stop you here and there and ask you pertinent questions and guide the examination. So here's a quick recap. Now, what is epiphora? Epiphora is excessive watering from the eye. The cause can be oversecretion or under drainage or impairment of drainage. But then you might also be asked, what's the difference between lacrimation and epiphora? So here the difference is in epiphora, obviously there is an oversecretion, but there might also be an impairment of the drainage of the tear, as a result of which the tears well up in the eyes and you will have watering from the eyes. But in lacrimation, it is mainly reflex tear secretion or an over secretion from the eyes in face of a completely clear and completely normal tear drainage system. So that's the difference between lacrimation and epiphora. Now, what are the causes? So the causes of epiphora, as I said, is oversecretion, number one, and oversecretion can be due to, irritation. So this irritation can be due to misdirected lashes, and these misdirected lashes can be due to entropion. Ectropion, of course, not due to lashes, but due to, impairment of drainage. Then it can have dry eyes. Dry eyes reflexly produce more secretion of watery tears. Laxity of the eyelids, in which case it will be a lacrimation pump failure. And you have also to check for blepharitis and canaliculitis. Obviously, a good hint of the patient having canaliculitis is that you will have a pouting punctum and it will be mildly painful and red. Examine the sac area for scar of previous surgery and presence of a fistula or other scars. Now, scar of a previous surgery, that is the webbing of the scar, is a very common complication. And next, you feel for the swelling. So note if it is tense and if it is painful. Also note that on exertion of pressure over the mass, what happens. So this is the ROPLAS test, which I had referred in an earlier slide. ROPLAS is regurgitation on pressure of the lacrimal sac. That's the acronym. Now, ROPLAS is important. As and how you do your examination, you'll have to see what is happening when you press over the sac area. And I have presented to you in a form of a table. So here are the findings and the interpretations. Please go through the slide. So clear mucoid or mucopurulent fluid comes out from the punctum. So this indicates a probable nasolacrimal duct obstruction. If you have blood tinged fluid, so you should suspect there is an underlying tumor or maybe a dacrolith, which is basically a small concretion inside the sac, and it causes trauma and causes some amount of serosanguinous fluid to come out. Next is the regurgitation, and there is no regurgitation, and the sac remains dilated, which means it's an encysted mucocele. You have just seen a picture in a previous slide. And the fourth or the fifth possibility could be no regurgitation and the sac empties. Now, what could this be? This could be an atonic sac or maybe an internal fistula which has occurred and it is draining somewhere in the nasopharynx. A slit lamp examination is again a must to examine the structures of the lacrimal drainage system. The punctum, the lid margins, the tear meniscus height, the tear debris, presence of Centurion syndrome, and presence of meibomitis. Now, these are all causes of epiphora. So you must see the punctum, whether the punctum is in apposition with the tear film or the lacus lacrimalis. The lid margins have to be seen, whether they are rounded or whether they are normal. The tear meniscus height will give you a clear indication of whether it's a drainage impairment or an excessive tearing. Tear debris indicates that it's a dry eye, again a cause of watering of the eyes. And Centurion syndrome is basically a little anterior movement of the punctum, and there's a gap between the lacrimalis, lacus lacrimalis, so it causes an impairment of tear drainage. And presence of meibomitis, obviously these are the meibomian gland inflammation, again a cause of epiphora. Now, diagnostic tests. Now, there are two things which you have to do in a case of dacryocystitis in management. So, you have to elicit the cause of epiphora, that is a watering. So, whether it is really due to a chronic dacryocystitis or it is due to some other cause. And the second one is where, if it is a dacryocystitis, where exactly is the obstruction in the tear drainage. So these are the tests which we usually do, and it guides our treatment accordingly. So diagnostic tests. Diagnostic tests in case of watery eyes will include an excretory test or the secretory test. Now the excretory tests are the checking for the anatomical patency of the tear drainage system and the function of the lacrimal outflow pathway, whereas the secretory tests check for evidence of dry eye and any cause of reflex hyposecretion. The anatomical patency of the lacrimal outflow path is tested by lacrimal irrigation, the so-called syringing, which you are very familiar with, and the diagnostic probing and dacryocystography. So these are the three important tests which we do to test the patency of the tear drainage system. Now, before we do that, we could do something which is totally non-invasive and can even be done on small children. That is the dye disappearance test. Now, in the dye disappearance test, the patients who have a nasolacrimal duct obstruction often have a tear-filled glassy eye as opposed to a frank epiphora. This is examined under slit lamp, and the tear film height at the lid margin, which is known as the tear meniscus height or the TMH, is examined. A normal TMH in you and me will be around 0.2 to 0.4 millimeter, but anything which is greater than equal to 6.6 millimeter would indicate that the patient is having some problem in tear drainage, and that is an indication that the patient might be having a dacryocystitis. So how do you elicit this test? 2% of sodium fluorescent dye is instilled in the conjunctival sac, and the patient is observed after around 5 to 10 minutes. And after this period of time, in a normal eye in which there is a normal drainage of tears, the fluorescent will be completely gone. It will disappear. But if it remains, then suspect that there is some tear drainage impairment in this patient. Now, how do you find that the sodium fluorescent is gone? So you see it under cobalt blue filter in a slit lamp. If there is no fluorescence, which means it has completely drained out. But please bear in mind that this is different from the fluorescent clearance test, which of course is a different test. Now, this is important in undergraduate. It is the so-called syringing, and this is the lacrimal irrigation. Now here syringing is something which you will be asked in details. The procedure of syringing, how do you do a syringing, this will be asked because it's important. You take a nettleship punctum dilator and you dilate the two puncta. And while you're dilating the puncta, it is important to straighten out the canalicula, the ampulla, the canalicula, and this is done by exerting a traction, a lateral traction on the eyelid margin. The patient is asked to look upwards, and in such a position, the patient is first asked to lie down supine, and then he is asked to look upwards, and then the eyelids are everted slightly, and then they are given a slight traction laterally, and then you do a punctum dilation with a nettle-shaped dilator. After that, a cannula, a curved lacrimal cannula is used, and it is threaded into the punctum, and this is further progressed, and after that we instill saline water, or sometimes we even add a little bit of chloramphenicol, which has got an intense bitter taste, and then we push the medicine or the saline into the sac. And we ask the patient that if he can feel any bitterness or any saline taste in his mouth. So this is how the test is done. And of course, a thing which I've missed out, that is you instill 4% xylocaine into the conjunctival sac before you do the dilatation. This was what I was telling you. Now here again there is interpretation of syringing. After you do that, you can have, a myriad of findings. Now, according to the findings, again, I have tabulated the interpretation. Again, this slide is an important one and you'll be asked questions on that. Suppose you have a regurgitation of clear fluid from the opposite punctum. Now, why do you do a syringing test? A syringing test is usually done to elicit whether there is an obstruction, and if there is an obstruction, at the level at which the obstruction is there. So it will give a fairly accurate idea. Now, how do you interpret and how do you arrive at a conclusion that the blockage is at what point? So regurgitation of clear fluid from the opposite punctum, this is a scenario. So what do you interpret out of that? Which means that the obstruction is in a common canaliculi, the lacrimal sac or the nasolacrimal duct, could be anywhere. So now if it's in a common canaliculi, it will definitely be a clear fluid each and every time you do that. If it's in a sac, you might have some amount of mucopleural fluid, after which it's a clear fluid. And if it is deep down in the nasolacrimal duct, it will usually be a fair amount of mucopleural fluid first coming out of the opposite punctum, and then you have the clear fluid coming out. So this can also further be clarified by tests. Now, mucoid or mucopurulent regurgitation from the opposite punctum after some delay with dilatation of sac. Now, this definitely is a case of a nasolacrimal duct obstruction, which is very deep down, because the sac fills up, so it distends, and also because a sac usually which is not draining will have mucoid material inside that is pushed out. So this gives a clear idea that it is an NLD obstruction. Immediate third scenario, immediate regurgitation of clear fluid through the same punctum while performing irrigation through one of the punctums. Now this is an individual canalicular block, so the water could not even reach up to the common canaliculus. So it just hits the obstruction, comes back through the same punctum, and obviously it is not admixed with any of the material within the sac, so it's a clear fluid. Regurgitation of mucoid or mucopurulent material through the lower punctum only while irrigating from the lower punctum with a hard stop. See, there are a lot of conditions here. What is a hard stop? What is a soft stop? We'll come in the later slides. So right now, just know that it's a nasolacrimal duct block associated with the upper canalicular block. Obviously, upper canalicular block is there. So no fluid is coming out from the upper the upper canalicular, and these fluid is being forced through the same canalicular. Now, scenario 5, patent irrigation with sac dilatation and residual stasis in the patient complaining of epiphora. Now, here it's very strange. The patient comes with watering, there is epiphora, but when you do a test, the patient says that I can taste the bitter taste or saline taste in my mouth, and there is a sac dilatation, which also eventually, if you give a pressure, it empties. So this obviously is an atonic sac, which means there's a pump failure. Patent irrigation, the last scenario, with regurgitation of some clear or mucoid fluid. So this is a partial NLDO, because there is a partial block. When you are forcing it, when you are like the hydrostatic is more than the physiological pressure, the water is going through the normal anatomical channels. So it is being forced. Otherwise, in the physiological scheme of things, the water cannot go or cannot drain. So it's a partial NLDO. Now, probing. Now this probing becomes important after you have done a syringing test, especially in that scenario in which I said it comes to a stop with a hard stop. Now, what is a probing? A probing is basically you trace the anatomical pathway and you try to feel if there is any obstruction. So you do this probing with the help of a Bowman's probe. There are plenty of calibers of the Bowman's probe, and that is mentioned in the instrument. Just like a Foley's catheter, you have the gauge which is mentioned. So the higher the number, the thicker it is, and the lower the number, the thinner it is. So whatever, we thread the canaliculi, and we try to, very gently probe into the sac. Now it has to come to a stop somewhere. So the stop can be a hard stop. You can feel it against a wall, against a bony wall, or it could be a soft stop, in which case it's a spongy feel. So now what are these hard stops and soft stops? Now these pictures are very important, and they are self-explanatory. So you see there is a probing which is being done through the lower canaliculi in the first picture, and it is patent, and it goes and it hits the bone. So the lacrimal bone is hit by the steel probe. The only thing which is intervening between the bone and the probe is the medial wall of the sac. So naturally there is less tissue, and you feel that it's a bony stop. In the second one, it's a soft stop. Now, how come it's a soft stop? Because what happens is it's a membrane which is blocking the common canaliculus. And when you're probing and pushing it and forcing it, the entire membrane is also being driven up against the medial wall of the sac. And hence you have a lot of tissue which is bunched up, and this will give you a spongy feel. So it's a soft stop. So soft stop will indicate that it's a common canalicular block. And the last one is basically a false soft stop. Now a false soft stop occurs when you do not pay attention and you do not put the lateral traction over the eyelid, which straightens out the canaliculus. So here the canaliculus itself gets bunched up, and the entire stuff is being driven against the medial wall of the sac, and you have a very spongy soft feel. If you have a very spongy soft feel, you should once again try by following the correct pattern of probing. Now Jones dye test. Now Jones dye test is indicated only when patients have a suspected partial obstruction of the drainage system. For instance, the last scenario in the previous table. Here epiphora is present, but there is no punctal abnormality, and the patient tastes saline in his or her throat on irrigation, that is syringing. Now you have a primary Jones test, and you also have a secondary Jones test. Now what is this primary Jones test? Here it differentiates between a partial obstruction of the lacrimal passages and the lacrimal pump failure from primary hypersecretion of tears. Now if you see the picture, then you see that on the left side you have a positive Jones test. Here what is done is, here again 2% fluorescein is instilled in the eye, and cotton tipped applicator is introduced into the nose, and we see whether the dye is collecting on the cotton tipped applicator. If the dye is collecting, which means that the patient is having a patent tear drainage system. So the epiphora might be due to hypersecretion, that is secretion which is occurring more than the eye can physiologically drain it out. So you are having epiphora, or maybe there might be a pump failure which is simply not being able to keep up with draining against the secretion. Now in the right side you have negative. So negative in case of primary dye test is you have the fluorescein, but the cotton tip applicator doesn't collect any fluorescein or dye. So what could be the possible interpretation? You could have a partial block, obviously, or you could have pump failure. So a partial block, again we do not know which stage at any query site I have written, that could be of unknown site. So we do, to find out whether where the site exactly is, we proceed on immediately to a secondary Jones dye test. Now what is a secondary Jones dye test? In this case, immediately after that we we wash out the residual dye from the conjunctival sac, and then we proceed to do, with clear saline, we proceed to do a irrigation test or a syringing, and then we find the results. Again, a cotton tip applicator is put into the nose, you do an irrigation, and you see whether there is dye in the cotton tipped applicator. If there is dye, it's positive, and if there is no dye even after you are doing it, so it's negative. Now, positive in the secondary Jones test means that the sac somehow was filled with the dye in the first place, but it was not being drained into the nasopharynx. So the dye had entered the sac, the distal NLD has partial block, as a result it was not being able to drain. And in case of negative, the dye had never entered the sac, which means that there might have been obstruction before the common canaliculus, or the pump was not working, so no dye entered. Now there are some other tests which they will ask you in the course of crossing, so that would be dacryocystography, it could be a nuclear lacrimal scintigraphy, and of course CT and MRI in cases where you have history that the patient had undergone trauma or maybe some nasopharyngeal surgery. And of course, another thing which has to be done in such cases is a consultation from an otolaryngologist has to be taken, so that he rules out the presence of polyps or a deviated nasal septum. These are relative contraindications for an external DCR, and also they have a higher failure rates, so you get a consultation from them also. Now, treatment. How do you treat a case of chronic dacryocystitis? So in a chronic dacryocystitis, obviously, you will go in for medical management, and in medical management, you have this, sac massage. So you ask the patient to massage the sac regularly after the patient has instilled antibiotic drop in his eyes. But be careful that this can only be given to a patient who is completely chronic and there is no acute inflammation going on. Otherwise, he will have facial cellulitis. So now, in case I'll come to this later also, that what are the indications of surgical treatment in a case of chronic dacryocystitis? This is a question which you might be asked. So surgical treatment, I'll tell that later, but surgical treatment. So what are the surgical treatment available? You have a Dacryocystorhinostomy or a DCR and its modifications, of course, and you could have a dacryocystectomy or a DCT. DCR. Now, this is a question which I ask my students, and any examiner might ask for that matter. So what are the principle of the surgery? So principle of the surgery is, bear in mind, is not the step of the surgery or not the procedure of how you do the surgery. It's what you do. So what is the guiding principle? A principle in Dacryocystorhinostomy is a channel is created in the between the sac and the middle meatus of the nasal cavity to bypass the obstruction at the NLD to facilitate normal tear drainage. And principle of DCT surgery is the sac along with a portion of NLD is removed, so that the sac, which is a nidus of infection and a source of recurrent acute and chronic dacryocystitis, is eliminated. Epiphora, however, is not addressed. So that is the principle of DCT surgery. And now the indications. So this is very important. So when do you plan to do a DCR? So if it's a primary acquired NLDO, you do a DCR. In case of a secondary NLDO, that is nasolacrimal duct obstruction, tumors, maxillary surgery, etc., you might have to do. If it's a recurrent dacryocystitis, every 3 months the patient he is fed up, so you have to do this. If it's a chronic mucoid reflux, so the patient always has dirt coming out of his eyes, it's unsightly and he wants to get rid of it, mostly due to cosmetic purposes, you have to do it, and it improves the quality of life, of course. And if it's a painful distended sac. Now, what are the contraindications of DCR surgery? Now, this is also very important. DCR is almost always indicated nowadays because it allows the preservation of the function of the tear drainage. So this is something in which we have to consider. So this is the surgery which is always done, except now what are the contraindications? So contraindications will become the malignancy of sac. Obviously, if you have a malignancy, you cannot operate on that and keep that tissue inside. You have to get rid of that tissue. So that is one indication or absolute indication of DCT and absolute contraindication of DCR. So in case of DCT, you do an extended DCT, which means that along with the sac and the NLD, you also remove as much of tissue as possible, the nearby tissue as possible. You could also do you could also have contraindications of DCR as extremely old patients. They are usually poor risk patients who will not tolerate such a lengthy surgery. Granulomatous disease of sac, for instance, tuberculosis, sarcoidosis, mucormycosis, vaginose, Crohn's. So these are all those diseases where the flap itself will not be amenable to surgery. You could have SLE or cicatricial pemphigoid, again because of the same reason. The flap itself will not be amenable to surgery and it will close in any case. And multiple failed DCR. You've done DCR, another surgeon has done DCR, you've done a conjunctival DCR, everything has failed. So it's best to get rid of the sac itself. Now, what are the types of DCR surgery you know? Again, another question that is very commonly asked in the exams. So first of all, here it's I think the order should be revised. It should be external DCR at number 1, followed by endonasal DCR and its modification. I mean laser DCR, ballonoplasty and all that. So that is dacryoplasty with balloons. Then you have within the external DCR, you have conjunctivo-canalicular DCR, that is also CDCR, conjunctivo DCR along with Lister-Jones tubes, and external DCR with silicone intubation. So these, except for the endonasal DCR, which is actually a cross domain, it's common between the otolaryngologist and the ophthalmologist. So in our hospital, it is usually the ENT department who does the endonasal laser surgeries. The others are the surgeries which we do, and all of them are done, including Lister-Jones tube. Now, before we wind up, there are certain common questions that are asked and you must be aware and be prepared. So steps of surgery. Steps of surgery is an easy question. It is asked, and if you are asked a step of surgery, you should be aware that you are not doing very well, I'm afraid. So he's trying to give you some marks here. So next, common complications. Complications is something which are usually asked. It's a very common question. So it's better to divide it into early, intermediate, and late complication. You can just read it off the slide. So early complication, obviously, of any surgery would be bleeding, followed by wound infection. Now there is something which is known as it should not be infra, it's intranasal synechia and delayed wound healing. Intermediate would be a rhinostomy fibrosis, granuloma, and corneal abrasions. Now, what is rhinostomy fibrosis? A rhinostomy fibrosis is basically where you do the ostium, where you create the ostium, the bony ostium. That part gets fibrosed, and in fact, that is the commonest cause of DCR failure too, external DCR failure too. Now, what are late, as I was referring to, webbed facial scar. Now, this is so common that a webbed facial scar is something which will give you a hint that a previous surgery over the sac has been done. A chronic fistula could occur, and a collapse of nasal bridge. So you could have a saddle nose. This happens when you, in your over enthusiasm, create a very big ostium, resulting in the collapse of the nasal bridge. It's rarely seen, but nonetheless. Now, what are the advantages and disadvantages of endoscopic DCR? Now, the advantages, why would you do endoscopic DCR? So, no scar, which is very important, especially in our female patients. Then, less bleeding, obviously, because the entire ostium is done by a holmium or a carbon dioxide laser. So, there is no question of bleeding here. and less post-operative morbidity because there is less amount of tissue trauma. So morbidity and early rehabilitations are the norm, and obviously it's less traumatic to the tissue. Now, what are the disadvantages? Contrary to the popular belief, this has a lower success rate. Its success rate is somewhere around 60 to 70%, as opposed to external DCR where the success rate almost approaches 90%. We could also have a long and steep learning curve because it's basically a endoscopic surgery. It has a long learning curve, and the instrumentation is extremely expensive. Now, one question which is asked, and your marking depends on this, that is, what are the bones that are broken during the ostium construction in DCR? All of you, please have this slide by heart. It's the part of the nasal bone, it's the part of the ethmoid bone, it's the frontal process of the maxillary bone, and it's the lacrimal bone. So these four bones are taking part in the ostium formation. So they have to be sacrificed partially or in full. Now, these are some other common questions which are asked. So this is the measurements, the length of the canaliculus, the NLD, the sac, okay, the fundus of the sac. The picture that is given alongside the photograph is, I mean, the picture is quite self-explanatory. So the only thing which is not given out there is the fundus. The fundus is a blank arrow, so the fundus is along 2 millimeter in height. And what is the direction of the NLD? The direction of the NLD is basically downwards, laterally, and posteriorly. And you also have the mechanism of tear film drainage. This you must read off. So very briefly I can tell you that it's a pump function, so the lacrimal pump function. So how does the lacrimal pump function? So tear drainage is basically dependent on two processes. One is capillary suction and the other is pumping mechanism. Now the capillary suction is basically the tears which are secreted by the accessory tears and the main tear gland. So they find their way over the cornea and around the tear eyelid margin, and they flow towards the lacus lacrimalis where they collect. Now that's a pool of tear, and it is into this lacus lacrimalis the punctum dips. Now, if your anatomy is such that it is normal and it is opposed normally to the bulb of the eye, so what happens is with each blink, the capillary action will push the tear towards the lacus lacrimalis. And after this, it's the pump function which functions. Now, what is the pump function? Now, as you blink, you close your eyes. So once you're closing your eyes, the pretarsal fibers of the orbicularis oculi, they sort of, you know, compress. So they compress, and they compress the punctum medially. So the punctum straightens up, and as the punctum straightens up, so the fluid which is already present in the punctum, it makes its way lower down, and the and the other fibers which are there of the orbicularis oculi. So what happens is they press upon the sac, and as the eye closes, the pressure will force the tear to drain into the NLD and hence into the nasopharynx, into the inferior meatus. But when the eye opens, the reverse happens. So what happens is the sac expands. As the sac expands, it creates a negative pressure. So this negative pressure, and it draws the fluid from the punctum which was dipping into the lacus lacrimalis, and so again the sac fills up with the tear, and it waits for the next blink, in which as you blink and close your eyes, again pressure is exerted, and this pressure forces the fluid. Do remember that there are two one-way valves in the entire system. So one is the valve of Hassner and the valve of Rosenmuller. So the Hassner valve is lower down in the NLD. It doesn't, as you blow your nose, it doesn't allow the nasal secretion to come into the sac, and the Rosenmuller doesn't allow the fluid to come back into the eye. So that's it. Okay, students. So thank you and best of luck for your coming exams. Keep your cool, answer well, keep your wits intact, and if you have any questions or queries or any comments, do contact us communicate with us in Google Classroom in the comment section. Thank you.